Healthy India by none other than SHRI ABHISHEK Kumar, who is IRS officer of 2006 batch. At present, he is Director-IT, National Health Authority, and Additional Commissioner, Income Tax. I welcome you, sir, from my core of my heart for uh, coming to our webinar at a very short notice. And as you all know, today's session will be moderated by Dr. Ashish Kumar Gupta, who is our program director, and he will be giving a detailed introduction of the speaker also. Our National Digital Health Mission aims to develop backbone necessary to support integral digital health infrastructure in the country, which is a very difficult job at the moment, it seems so, and shall create seamless online platform through provision of wide range of data information and infrastructure services. National Digital Health Mission is going to create a system of personal health record based on international standards that will, also help us in maintaining security, confidentiality, and privacy of health-related personal information. And national portability in provision of health services is definitely going to be a challenge. I'm sure it is going to help all of us in enhancing the efficiency and effectiveness in governance at all the levels. How it will be done, I think let's listen to Dr. Abhishek Kumar, who's here today to tell us about the National Digital Health Mission. I once again welcome you all to the webinar and wish this weekly webinar, a great success. Thank you. Over to Dr. Ashish.
Thank you, President Sir, for introducing the topic. The speaker today, as President has told you, is none other than SHRI ABHISHEK Kumar ji. He is an IRS from the 2006 batch. He is holding a position of Additional Commissioner Income Tax. Presently, he is a Director-IT at National Health Authority, which is looking after this digital health mission. The details of the program will be and the components will be handled by SHRI ABHISHEK Kumar ji. But for the participants, I must add that if they want to ask any questions, they can put in the chat box as the lecture proceeds, and in between, as per the convenience, the speaker will respond to the queries, or I will compile the queries and put them together to him at one point of time. Sir, your talk time will be around 40-45 minutes. And we'll have at the end about 10 to 15 minutes of discussion and question answer sessions, right? And I also request all the participants to keep themselves on mute mode except the speaker. Over to you, sir. Mr. Abhishek.
Thank you. As we know, humanity is passing through unprecedented times these days, and because of a pandemic called COVID, entire humanity is passing through a stage of crisis. So during these times, everybody is realizing the importance of digital intervention in healthcare sector. Reason is quite obvious. COVID is a contagious disease, and everybody feels afraid to step out of home, especially to visit any medical facility. People have developed a sense of fear, and for right reasons. So, if the digital interventions are effectively made in the healthcare sector, which reduces the need for physical interactions, and if medical facilities can be availed of without any physical visit, that will obviously be a major gain in the healthcare sector. So, National Digital Health Mission, which was launched last year by the Government of India, primary objective is to create a digital healthcare ecosystem. This is a relatively new concept, and I must say, digital intervention up to this scale probably has not been experimented anywhere in this world. So we need to understand this concept fully, and we need to understand the potential of this intervention as far as the capability to improve these healthcare services are concerned. So let me share one presentation which will help me explain the mission and discuss it in detail. Okay, so I hope screen is visible.
It's available, sir. Is there?
Okay, so this is the vision of NDHM. Vision of National Digital Health Mission is to create a national digital health ecosystem that supports universal health coverage in an efficient, accessible, inclusive, affordable, timely, and safe manner through provision of a wide range of data, information, and infrastructure services, duly leveraging open, interoperable, standards-based digital system and ensuring the security, confidentiality, and privacy of health-related personal information. Here, one of the key elements of National Digital Health Mission is to establish an interoperable standards-based digital system. I am especially emphasizing on this term, and we will discuss in detail in the subsequent slide why interoperability is so important in any effort to establish digital healthcare ecosystem. So, what are the objectives of establishing this project? Key objectives are to establish state-of-the-art digital health system and management of health data, improve the quality of health data collection, storage, and dissemination. It aims to provide a platform for interoperability of healthcare data. It aims to fast-track creation of updated and accurate health registries for the entire country. And obviously, the entire objectives are reduced to better provisioning of healthcare services for the citizens. So, now coming to the problem statements which this project aims to solve, because as we know, many times many initiatives are taken and we are not clear exactly what is the set of problems which are intended to be addressed through that initiative. So as on date, what are the challenges? Citizens do not have handy access to all medical records. Citizens do not have handy information about doctors, hospitals, and labs. They may not be having sufficient knowledge about qualification of doctors. The choice to consult doctors remotely, and this part I discussed in the beginning, that in times of a crisis like COVID, the capability to consult doctors remotely has become very important. So the choice to consult doctors remotely is very limited as on date. Then easy supply of medicines. So these are the problem statements for citizens. Now coming to hospitals, labs, doctors, that means the healthcare providers. What is the challenges with them? Again, few problems are quite similar for all stakeholders involved in the ecosystems. Like citizens do not have access to all medical records. Similarly, healthcare providers lack access to patients' complete medical history. Then ability to ensure follow-up after treatment, feature to remotely consult patients, and ease of doing business. When we say ease of doing business, it means so many things like capability to access patients, capability to communicate with patients, capability to get various kinds of regulatory clearances and licenses required. Policymakers and program managers, they are another key stakeholder in this healthcare ecosystem. And as we know, during COVID times, this point was realized by everybody that handy and quick availability of data is very important for policymakers to handle any crisis condition. Like suppose for COVID, government gets data about geographical spread, the timelines, how the disease is progressing with time, if various kinds of modeling can be done, those things would obviously be very helpful in handling any such condition. Not only that, various kinds of medical research can also be conducted based upon the data. So, sufficient information about various kinds of diseases is very much imperative for policymakers and program managers to make effective intervention. And complete monitoring and control in unified manner. That is what is required by policymakers to make effective intervention and effectively control any disease or especially crisis condition. So let us go to some key points, because these days use of information technology is quite common in any sector. So probably at the first sight, we may find it difficult to understand what is so great about digital interventions in a healthcare sector. Just like any other sector, making software is not such a big deal in these times. So what exactly is the challenge? We saw vision statement of NDHM. It aims to create an interoperable healthcare ecosystem. So NDHM is not like any other traditional health scheme. It seeks to create an interoperable ecosystem. And when we say ecosystem, it includes everything. Various programs, various schemes, various hospitals, labs managed by government, as well as private hospitals, labs, clinics, each and every party who are engaged in the healthcare ecosystem that is within the mandate of National Digital Health Mission. Why? Because we seek to create an interoperable digital ecosystem. So, an interoperable ecosystem cannot be created unless all the stakeholders are taken into account. An interoperable system will be meaningless if it talks about only government hospitals or labs. So, all the stakeholders engaged in the healthcare ecosystem are part of this intervention. As on date, there are various interventions in healthcare segment. There are many hospitals and labs which use various software, HIMS, LIMS software systems. health information management system and lab information management system. But these digital interventions are quite fragmented and there is no interoperability among these systems. But what is the precise requirement to ensure interoperability? So let me explain interoperability again in layman terms. When a person visits, let us say, AIIMS Delhi, so a local ID is assigned by the HIMS system at AIIMS Delhi. Tomorrow, if the person visits some other hospital at Bhopal, so in that case, that hospital will assign another ID to that person, which mostly we use term UHID. In the digital system, these two IDs are two different entities. So suppose if I am assigned two different IDs by two different systems, the digital system can't identify that it is the same system which has got treatment in two different hospitals at two different points of time. So first of all, we need a common set of identifiers for unique identification of all the stakeholders in the ecosystem. And when we say identifier, it is not just for patient. A patient may be identified by a health ID, a healthcare professional may be identified by a healthcare professional ID, a hospital or lab may be identified by a facility ID. So similarly, all the key stakeholders need to be identified by a common identifier. Only then we can think about creation of an interoperable ecosystem. Next point is health data standards. So what are the various health information which is generated in a healthcare ecosystem? There are various kinds of report like prescription, discharge summary, diagnostic reports. So certain common health data standards need to be defined because digital systems can't make any meaning of any document or any data set unless standards have been clearly defined. And those standards need to be clearly adopted by all the players in the ecosystem. Now, for creating an interoperable healthcare ecosystem, it is not just about creation of common set of identifiers. So we just a second. Okay, sorry. So I hope I am audible, right?
You are, sir. You are audible.
Yeah. So I was discussing challenges in adoption. So when we talk about creating an interoperable healthcare ecosystem, it is not just about establishing common set of identifiers and health data standards. Through NDHM project, we are already in the process of creating common set of identifiers, various registries, and health data standards are being notified. But what is equally or more important is that these registries and standards need to be adopted by various players in the ecosystems like doctors, hospitals, labs, and HMIS software providers. They need to adopt these standards. Only then an interoperable ecosystem can be created. One related problem is that mostly we have learned during the execution of the project that mostly doctors find it difficult to operate through any HMIS software system. And mostly people are used to paper and pen kind of system where they see any patient and they start writing the prescription. So these are some of the key challenges in execution of this project, and we understand that any such project can be successful only after active adoption of this project, the concepts of this project, and support and cooperation from all the stakeholders. Now, coming to basic guiding principles of NDHM. The first basic principle of NDHM is that participation is voluntary. That means nobody can be forced to participate in NDHM, be it individuals, doctors, labs, hospitals. For everybody, each participation in NDHM is up to the choice of that individual or that entity. So what does this participation means? I will discuss in detail in subsequent slides. Next, privacy and security by design. This is one of the key principles of NDHM. We understand that in NDHM, we are dealing with health data of an individual, which is very sensitive and personal kind of data. So privacy and security has to be maintained by design. Inclusivity. Although this is a digital project, but we understand that a large part of India may not have very handy access to digital tools or internet connectivity. So accordingly, provisioning is being made for making benefits of this project available to all those people. Seamless portability. It is about interoperability of the system, which I discussed earlier. Federated architecture. So this point is very important here. Instead of centralized architecture, in NDHM we are going to adopt federated architecture. What it means? Federated architecture means that there is no plan to create any centralized repository of healthcare records. And one of the key reasons because of which federated architecture has been adopted is the understanding of personal nature and sensitive nature of healthcare data. So any data, any healthcare data which is generated at any facility, any hospital or any lab, it will remain at same place. Only the indexes will be stored at the level of consent manager of our centralized system. So I will explain this aspect in detail when we go to subsequent slides. The crux of federated architecture is that no centralized database of healthcare data will be created, and the data will remain as it is being maintained as on date. Next is longitudinal records. This is one of the key guiding principles as well as objective of this NDHM. So far, we discussed about interoperable ecosystem, but from the perspective of the patient, what is the gain? As on date, all of us know that it becomes difficult even to find out 3 months old medical record, diagnostic report, and mostly we operate in paper pen kind of model. So the records are lost. Naturally, if the medical records of a person over the period of time and across medical facilities, if they are available, it will definitely improve quality of care and ease of care for each and every individual. It will be a great benefit for individual as well as healthcare providers. So how did journey to National Digital Health Mission begin? It started with Sustainable Development Goals, then National Health Policy 2017. It lays down a strong emphasis on development of registries for facilities and providers. So I hope everybody is clear about the meaning of the term registry. When we say the term registry, it basically means the set of identifiers, the database which acts as single source of truth for any facility or provider. establishment of a federated national health information architecture is key to national health policy. Then National Health Stack 2018, it was published by Niti Aayog. Again, it talks about electronic registries and federated PHR framework. Finally, all these efforts culminated into National Digital Health Blueprint. It was published in December 2019. This document was published by Ministry of Health and Family Welfare. Wide public consultations were conducted before finalizing this document, and this document is available in public domain. So basically, this document is the foundation for our project, which is National Digital Health Mission, and it defines the basic framework for implementation of this mission, various building blocks, standards, regulation. So it is a kind of foundational framework for implementation of National Digital Health Mission. So as I discussed, NDHM seeks to create an entire ecosystem, interoperable healthcare ecosystem. So you can see in this picture, it covers all elements of healthcare ecosystems, be it providers, hospitals, allied private entities, healthcare professionals, associations, regulators, central government, state government, UT government, policy makers, administrators. Each and everybody is engaged in the entire scheme of things. So just to clarify things further, let me make one analogy here. Just like UPI or BHIM intervention revolutionized entire payment and banking framework of the country, National Digital Health Mission is similar kind of initiative in the healthcare sector. When UPI, Unified Payment Interface, and BHIM applications were launched, at that time, sufficient degree of digitization of financial market had already taken place. What was lacking was interoperability. Like on consumer side, there are various kinds of applications. There are various banks. There are various mechanisms of payment. And there is no interconnect on payer and payee side. So that UPI intervention bridge that gap, that irrespective of the application being used at consumer level or at pay level, the application or payment transactions can work. So we can, this NDHM project can be seen in analogy to that UPI intervention. So let me explain this NDHM solution a little bit in detail. What are the key elements of this National Digital Health Mission? Health ID is one key element. Every individual is to be assigned a health ID, and obviously it is up to the choice of the individual. Various registries are to be created. Partly it has already been created. I will discuss in subsequent slides, like doctors, healthcare professionals, hospitals, labs. They can visit NDHM portal and they can register themselves. Electronic health record. So once an individual creates a health ID and starts registration in various hospitals using a health ID, then all the medical records get linked and we can create something called electronic health record, which is nothing but consolidated medical records of an individual over the period of time and across hospitals, labs, and facilities. Next is open standards and open APIs. This is a little bit technical terms. In layman language, what it means is that they will enable interoperability in the system, and anybody adopting standards and APIs will be able to communicate with the other digital systems who have adopted open standards and open API. So using health IDs, registries, open standards and open APIs and interoperable healthcare ecosystem can be created. Access to EHR. So an individual will be able to access electronic health records on mobile. Not only access, the individual can share medical records based upon consent. So I will discuss in detail when we go to subsequent slides. At broad level, these are the key elements of NDHM solution. And going ahead, once all these registries are reasonably populated, health IDs created by a substantial number of people, open standards and open APIs are adopted by various software solution providers as well as hospitals, labs. After that, something like anonymized data can be used for analytics and research. Research means broadly two kinds of research: policy level research and medical research. So at the end of the tunnel kind, that means once the solution has matured to a significant level, we will have sufficient anonymized data to be leveraged for the purposes of analytics and research, which is expected to greatly improve quality of medical care. Now, in NDHM, we have created various kinds of constructs: HIP, HIU, and HRP. What is the meaning of these terms? So HIP means health information provider. So any hospital, lab, clinic, they are basically a health information provider in our construct of NDHM. So any entity which is generating health information, that is a health information provider. What is a health information user? So any entity which is using that health information. So it may be again hospital, labs, clinics, because they might be using data generated at some other system, as well as, let us say, policymakers, research institutions. They will qualify as health information user. Health repository provider. Health repository provider is basically hosted HIMS solution. So as on date, there are various HIMS solution provider. If we talk about various government applications, then there are applications like e-hospital, e-Sushrut, which are being used in various government hospitals across India. Apart from that, there is one more concept called health locker. So concept of health locker is similar to DigiLocker concept. So I hope everybody is aware about the concept of DigiLocker, whereby anybody can store one's medical record in the locker. So this is the broad architecture of NDHM. There is no need to get into technicalities of these things. Broadly, what it means is that on left hand side, we have healthcare information providers. So these are our HIP. They are using either their own software or some other hosted software like e-hospital, and the medical records are being generated, right? On right hand side, we have various public health program, hospitals, various kinds of application, let us say telemedicine application, who wish to use the healthcare information. So how NDHM solution facilitates this interoperable ecosystem, and how transmission of information becomes handy. So any individual who has got health ID, the record being generated at this hospital is linked to a health ID. And the moment any information is generated here, it is like email notification kind of thing, that hospital or hospital software sends a notification to consent manager that, see, I have got a medical record pertaining to this health ID. So medical records remains at this place only, but through this notification, this is another digital system called consent manager, and consent manager knows that there is a medical record pertaining to this particular health ID at this hospital, let us say AIIMS Delhi. Similarly, an individual can decide to partly store medical record in a locker as well, so the record may lie here as well. But naturally, a copy of the record is always there at the hospital. This is DigiDoctor, which is nothing but doctor's registry. This is facility registry. So the linkage of the medical record is maintained with respect to these doctor's registry as well as facility registry. So any record generated at any hospital has three key identifiers. One is identifier of the patient, other is identifier of the doctor, and one is identifier of the facility, that is hospital where the record was generated. So suppose some telemedicine application on this side, somebody is availing telemedicine facility. So the doctor sitting at the other end of the telemedicine application wants to see earlier 1 year record of the individual, right? So through telemedicine application, a notification will be sent for last 1 year's medical record. Once the doctor makes the request will land at the mobile application of the individual. And only if the person says yes, the record can be sent. Only then consent manager permits transmission of medical record from here to here. And no medical record is stored in this building block. This building block constitutes core of NDHM. So this slide is little bit technical, but I hope you are able to make sense out of it. So I will take 5 minutes more to explain it. As on date, there are 4 key building blocks which are already launched in 6 union territories of the country. It was launched on 15th August last year by Honorable Prime Minister. So as on date, health ID module is active. Anybody can visit healthid.ndhm.gov.in and create health ID. Similarly, a doctor can visit digidoctor.ndhm.gov.in and register. Any facility can be registered by visiting facility.ndhm.gov.in. But one caveat, currently the project is rolled out only in 6 union territories and it is not launched across India. Now, this 1, 2, and 3, they are merely digital registries. The question comes, what is the benefit gained by the end users? So, this is the one application, NDHM Health Records application, which is a mobile application. It is already available on Google Play Store. Anybody can visit Google Play Store and download this application. This is the citizen-facing application on which longitudinal medical records become available. How? Let me explain it step by step. So, how does end user experience changes with NDHM? As on date, somebody visits hospital, registers at the registration counter of the hospital, then visits doctor. Doctor writes prescription and other medical records, and after that person goes out of the hospital. So with the NDHM, how it will change? The person goes to a hospital. The person can register at a hospital using health ID. It is absolutely up to the choice of the individual. It is not mandatory. If the person is not having a health ID, the person can create health ID at the reception counter of the hospital. Now, any records generated in the medical record get linked to the health ID at the choice of the individual. So it is not such a great thing in the sense that even now, when we visit a hospital, a local ID is assigned in the software system of that hospital. Now, once the person comes out of the hospital, the person will receive a message that your records are available for view. Please download NDHM Health Records application to view your record. Once the person downloads that app, the person can register using a health ID, user ID and password. And after that, the records generated at that hospital will be visible on the mobile screen of the individual. Not only visibility, suppose, as I said, if the person is taking any advice through teleconsultation and the doctor is requesting for some medical records, through this application, the person can give consent for sharing of medical records and the doctor will be able to see medical record of that individual. So this is the key benefit which will be gained by the end users, that is citizens or patients. But a basic question here is whether this capability to register using a health ID and linking health records to a health ID will be available at all hospitals across India? No. The hospitals or labs need to adopt NDHM, and only the hospitals linked to NDHM digital system will be able to provide this capability. So NDHM operates in plug and play kind of model. You can take a correspondence to UIDAI Aadhaar system where somebody can be authenticated by leveraging UIDAI system. In the same manner, NDHM operates in plug and play model. There are 4 kinds of entities or constructs, as I explained earlier. Any hospital, let us say AIIMS Delhi wants to integrate with NDHM. So what they will have to do, there is a sandbox of NDHM, sandbox.ndhm.gov.in. They will have to register there. There is a approval process, digital integration process, which they will have to complete. And after that, they will get production access key. After getting production access key, that hospital gets linked to NDHM, and then any patient will be able to register using a health ID and see all the medical records on the NDHM health records mobile application. So as on date, the status of the project is that it is rolled out in 6 union territories. The plan is to expand it in various states and union territories. Various services are to be expanded, and going ahead, there will be nationwide rollout. So that's all about NDHM. So I hope I have been able to explain key concepts of NDHM, and if there are any questions, we can discuss it further. Thank you.
Thank you, Mr. Abhishek Kumar, for very crisp and elaborate presentation on an NDHM initiative on electronic medical record and centralization of the medical record. Now the topic is open for discussion. Anybody who wants to ask a question can unmute himself and ask a question to him.
Good evening, sir.
Go ahead,
Sir, thank you for the wonderful presentation, sir. I just had one doubt. What about the EHR companies or EHR solutions that are already there and are being used by different, private and other trust-based hospitals? What if they do not want to be a part of NDHM because that would entail some structural changes within their softwares? So, like if they do not want to play by the NDHM rule, is there any way you can? I mean, is there any law or something which can force them to do it?
Yeah, so very good question. So as we discussed, NDHM is not about creating just a digital system. It is equally important that people in the ecosystem adopt NDHM, and only then true value of NDHM will be realized, right? So First of all, NDHM doesn't require any fundamental change in any software, right? Any HMIS software system needs to complete integrations with NDHM. And what does this integration means? Integration means only two things. That they need to use NDHM identifiers. Secondly, they need to comply with NDHM health data standards. So it is like creating a wrapper over the existing software. So as such, it is not a very major or fundamental change in any HIMS system, right? Already there are so many players, more than 350 players who are integrating in our sandbox, and they are at various stages of integration. There are around 8 software solutions which are already live with NDHM, but definitely it will require a push. The push can be either in terms of incentive and disincentive structure. It may be even in terms of regulatory framework. So we are working upon all these aspects, and let us see how it goes.
Right, sir. So basically, as on date, there is no law, or if there are some companies who do not want to play by the rules or play with NDHM, it's fine, right, sir? As on date, they do not have any problem. They will not have any problem. Just for my better understanding.
Yeah, yes, you are right. As on date, there is no legal requirement. There is no regulatory requirement as such to comply with the NDHM. And see, we need to see this initiative little bit from market perspective as well. Everything doesn't work simply by virtue of law. And I gave example of UPI. UPI worked not because it was mandated or dictated by some law. Once people start seeing value proposition in some initiative, it leads to adoption. And definitely there are various stages of adoption. Once a critical mass adopts it, people start gaining better visibility to benefits of the project, and it leads to faster adoption.
Absolutely, sir. And it is very heartening to see that the approach is not top down. It is more of a market driven thing. That's a wonderful initiative, sir. I mean, kudos to your team. So thank you for that.
One question from my side, as with respect to the interoperability issue, will NDHM provide some type of model HMIS, because people have their own HMIS now to interface with their own HMIS, or they do a drastic change in their HMIS, the hospitals and the providers?
Yeah. So as I explained, NDHM role is limited to prescribing or not prescribing, rather building registries and prescribing standards and open API specification. So HMIS system, as I said, there is no need of any fundamental change in any existing HMIS system. The HMIS system just needs to create a wrapper over the existing software, and that happens through our sandbox integration process. We definitely have prepared one sample EMR software that is just a reference application, and the link is available on the NDHM portal. As far as hosting of that solution is concerned, it will be required to be done by respective facilities.
I have a question. Can I ask?
Yes. Yeah, please.
Yes, sorry.
Yeah, I'm Dr. Chandrasekhar. In fact, I served ministry for 32 years and still working with at the various level. I have understood that such a wonderful initiative, whenever it is recommendatory, people have a tendency to, neglect. And when you have to achieve this goal, you have to find out how to make it a mandatory effort, maybe slowly, because in our country, any step you move, immediately there will be 100,000 voice coming in a different format. The way when we started with NABH, and then over a period of time, we started telling those CGHS, those people who want to empanel with CGHS, are you in any NABH accredited? So indirectly, we inducted them that better you get yourself accredited if you want to be in the part of the system. So somehow you have to find out a method, because recommendatory never works, mandatory works. And that has been the experience everywhere. So kindly, this is a suggestion that how to find out and make. Right now you have started with only union territories, and I know even when we worked on the NOTO and the organ transplant, and what kind of a small thing, every step we face the challenges. So I also request your team to look into this, direction. That's the only thing which I wanted to. Maybe you must be working on it, so you can elaborate or explain if at all you are doing so.
Yeah, so I fully appreciate this point, and we understand that since adoption of NDHM is very important, and it is not a government subsidy program, so because of that, there may be lesser drive, at least in the beginning, to adopt this project. So we are definitely exploring various options, including incentive and disincentive structure, as well as exploratory exercises being done, whether any regulatory framework can be built for the healthcare sector in general, which can lead to better adoption and better interoperable system. But at the same time, we also realize that it has to be a mix of incentive, disincentive, as well as whatever regulatory framework comes out as a result of detailed brainstorming at various levels and involving various stakeholders.
Sir, I had one doubt. Sorry, I mean, just one more question. Sir, people who want to come on board NDHM, is it mandatory that they should use the DigiLocker, or can they have their own data centers and they can be the managers of health information?
No, see, there are two things. On one side, we have patients, individual. So it is for the individuals to decide whether they wish to use health locker facility or not. And we are going to provide them 1 GB free health locker space. So this facility is limited to individuals. When it comes to hospitals or lab who are using their own HIMS system, there is no provision of any locker for them. HIMS system has their own hosting facilities, data center, whatsoever. There is no provision of locker for facilities. It is for individuals, and it is up to the choice of individuals. So I hope it is clear to you.
Right, sir. Right, sir. Thank you, sir.
A question from my side. As we normally say, that data is a business asset, and sometimes it is of very sensitive nature. Are you trying to foresee some problems from the stakeholders like providers, doctors, and hospitals in sharing the data of sensitive nature or business nature on this portal at NDHM?
Yeah, so this is a very pertinent question. So as I explained, in NDHM, we are not creating any centralized repository of data. Data remains at the source, that means at the hospital. Suppose as on date, AIIMS Delhi, and I am repeatedly giving example of AIIMS Delhi only. I can't think about any better example as of now. So suppose a particular hospital is using some particular HIMS system, and the data is being stored at cloud. So the data will remain as it is. Only the indexes are being stored at consent manager level, and that is the way linkage is being established. So any personal or sensitive personal data can never be shared without consent of individual. That is the framework as on date, and that is the legislation proposed as part of PDP bill, Personal Data Protection Bill. So largely we are going by that. But how to leverage data, that is another aspect, and that is where anonymized data comes into picture. So we are yet to prepare very detailed framework for that. But just for knowledge of everybody, we have already finalized and published our health data management policy. Health data management policy is available on the website of NDHM, ndhm.gov.in, and There we have discussed anonymized data can be leveraged for various kinds of research and other usage, but the detailed framework is yet to be published.
Sir, in continuation with that, another question now comes into mind. Suppose there is a loss of data because the data storage is peripheral. Now, suppose there is a data loss at AIIMS level, AIIMS Delhi we call now, a favorite example we are giving. So what happens to the longitudinal medical record of the patient?
Again, since the data is being stored at AIIMS Delhi, any loss to data can happen only if something goes wrong with the HIMS system of AIIMS Delhi. NDHM has nothing to do with primary storage of data. That will remain with the original hospital. So hypothetically speaking, if something goes wrong with NDHM system, only the linkage may be lost. The record as such will remain at the hospital. And NDHM application, what does it do? So let me explain a little bit more. Suppose I am using NDHM health record application to see my medical record. And suppose I have my medical records across 5 different hospitals. So only the links are available on the screen of my mobile. And when I click those links, the records are pulled at runtime from those hospitals to my mobile.
That's what is my concern. Suppose out of these 5 entities, data at 2 entities has become corrupt. So now what happens to the total medical record of that case? Because from 2 links, the data is not coming. What happens?
Yeah, so that's a valid point, and that risk can be partly mitigated. See, we are doing 2 things to mitigate that risk. First, any healthcare facility which is getting integrated with NDHM through the sandbox process, they have to comply to something called HIP-HIU guidelines. It is already published on the portal of NDHM, and as part of those guidelines, the hospitals have to ensure that their server is up and they any NDHM health record application is able to pull record through the link whenever the patient wants. So that is a guideline kind of thing which is required to be complied with by any entity integrating with NDHM. Another part is that we are provisioning for health locker as well. So that protects against that risk. If somebody has got records across 10 different hospitals, they can choose to upload it in some locker through NDHM health records application only. Not only records generated at a hospital, they can even scan and upload their earlier records. So that becomes another measure to mitigate the risk as stated by you, but that risk is definitely there, and we are trying to tackle it through these 2 measures.
Sir, I had a doubt. Like in case of data breaches, or in case the data leaks from some hospital, because NDHM is a pan-India network, there's some hospital somewhere, and where there's a data breach or a data leak. So in that case, my first question is, if the hospital is not on the NDHM network, what would be their legal liability for any particular data breach as on date? And the second possibility is, if the same hospital is on NDHM network, then would that decrease their legal liability for any form of data breach?
Yeah, so very good question. First of all, NDHM doesn't seek to create an entirely new healthcare ecosystem. And I am telling this point to make the basics clear. Whatever healthcare ecosystem is there, that is already there. NDHM is just like creating an additional layer over the existing healthcare ecosystem so that a layer of interoperability is created. That's all. So if any hospital doesn't comply with some legal provisions, or some data breach happens because of negligence of, let us say, any hospital or a hospital staff or any hacker or any third party, the legal liability or regulatory liability remains the same. NDHM doesn't increase or decrease it. So legal provisions remain exactly the same. there is no change in it as far as NDHM project is concerned. Right?
Okay, sir. Okay, sir. And sir, as on date, I mean, just as a hypothetical scenario, sir, let us say there's a 100-bedded hospital somewhere in the periphery, there's a data breach there. So as on date, what would be the legal liability on part of the hospital or the software provider, sir, as on date? I mean, just for my learning, sir.
Yeah, so see, for that, we will need to examine the provisions of Information Technology Act as well as other relevant acts. I am not aware about the exact provisions, because in such cases, complete set of facts will be required to be examined. Who is responsible for such a leak? All these facts will be required to be ascertained, and only after that applicability of respective law will come into picture.
Yes,
Right?
sir. Got it. Thank you, sir.
Good evening, sir. One question from my side. I'm Dr. Atul Kumar. I'm just wanted to know, because lot of doctors, whether in the private services or the government services, using pen and paper method. So from the NDHM side, what you have planned? You have planned to provide any type of incentive or something like mandatory to do to join this? They're forced to with the NDHM system, so that data can be generated as per your convenience.
Yeah, so there are 3-4 elements which need to be seen. You have pointed out a very pertinent problem, that there may be n number of software, but how to make the doctors adopt and use that software. So in fact, with respect to that question, I will be looking for suggestions and answers from you rather than me giving the answer. But as far as we are concerned, there are 3-4 related elements. First is, when it comes to prescribing data standards, we have adopted an incremental approach. We understand that if we make data too much structured and put too much liability upon hospitals and doctors, since habits of the people do not change overnight, it may lead to resistance in adoption. People may not feel enthusiastic to adopt it. So if you see health data standards like prescription, discharge summary, their templates are already available on the portal of NDHM. The link is available. You can see it. We are prescribing for very little metadata, like basic demographic data and the type of record. Regarding rest of the fields, we are giving an option to the people that either you can upload it in very structured using various terminology like SNOMED, CT and all those standards, or you can even upload a PDF file, or you can enter free text. So we have kept the system little bit liberal in the beginning, so that people are tempted to adopt it and there is not much resistance in adoption. Second point, we are also exploring from technological perspective whether we can leverage various technology like NLP, natural language processing techniques, so that without forcing somebody to use the software, those records can be generated electronically. And third point, we are just like this interaction, we are working with the stakeholders to understand various nuances and how people can be made to adopt this HMIS system while understanding the practical difficulties faced by them. Right?
Thank you, sir. Thank you, sir. Just one more suggestion, and I would. This is a request from my side that we are the graduates of the All India Institute of Medicine in New Delhi, and we have done a study. I would like to share with that study, and we are conducting another study in the second phase. So definitely, I will meet you and share with our thoughts regarding this, how to adapt this organization. Thank you very much, sir.
Yes, welcome.
Sir, just a small request. I and Dr. Atul are colleagues, so we have put up the link on the chat box in the meeting chat box. So it's a small Google form link. Again, sir, as you were rightly pointing out, that we need to know the factors that actually influence the adoption of digital health among doctors. Because in the market, if we see there are hundreds of software providing companies, but the adoption is really low. So we are doing a scientific study in this regard. So I would just request all the dignitaries in the meeting, if they could participate and they could forward the link, to their other fellow doctors. We've already got around 970 doctors to participate from across India, sir, from different levels, right from the primary healthcare center level, in villages till, super specialists in, metro cities. So we would request if, we can get a little more responses. I think we would be good to go in once we touch 1,000 responses. Yeah. Thank you.
Thank you. Any questions, sir? President, sir, Dr. Yashpal, any question from your side? Dr. Pawan? Any comments? President, sir?
Yeah, thank you very much. It was a wonderful presentation. We really appreciate Dr. Abhishek's initiative, and we wish him good luck. And I think future is in digitalization only. We have Dr. Rajesh Valla also here. Sir, anything from your side? Please unmute yourself.
Unmute. Yeah. Sorry, I was muted. I think that was a beautiful presentation, and I think the future of digital India is very much over here. There's no doubt about it. And medical fraternity is no exception to that. Thank you. And thank you to Mr. Abhishek Kumar, as well as to the AHA organizers.
Thank you, sir, and thank you, Dr. Yashpal, for arranging such a beautiful talk on National Data Health Mission. I must thank Mr. Abhishek. I've heard him for the second time, incidentally, on the same subject. I heard him earlier and in a CAHO conference. So it was a wonderful presentation. I think very well simplified the entire National Data Health Mission. I know there are a lot of queries in everybody's head, but I'm quite clear in what he has spoken, and whatever he has given, it is there that the individual data is to be maintained by the healthcare sector, by the providers, and by everybody on their own platforms as they be it. NDHM, National Data Health Mission is only trying to integrate everybody. It is serving as an integrator and facilitator of information rather than taking the responsibility of the entire information with themselves. So that is what NDHM is trying to do, and he has very beautifully brought out everything, and we are very grateful to you, Mr. Abhishek, for clarifying a complex matter into such simplistic manner. And I'm grateful to the President and Ashish for having given an opportunity for all our members.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.
Good to hear you, Pawan.
Sir, same here, sir. Nice to see you too, sir. I just put myself back on the camera, sir.
I know you're hiding behind the wheel.
Now, I was taking down notes, sir. Last time I did not take down notes, so this time I took down notes on what was being said. And I was actually filling up the pro forma given there, and I was shaken up from the filling of the pro forma actually.
Dr. Hemchandra, you want to say something?
Unmute.
Unmute yourself, please. Dr. Hemchandra, unmute yourself.
Thank you, Mr. Abhishek, sir. It was a nice presentation. In fact, I was fully prepared to listen to the thing, but meanwhile I was a little bit busy also, but remain interrupted for me. But I got many things from this particular webinar. The requirement of the hour is definitely NDHM, and I support and agree with the statement of Honorable Vice Chancellor and our teacher, Professor Pawan Kapoor, sir. And it is a requirement that individual data and all the information to be made available on the card every time in checks you have. So thank you very much for this nice presentation, sir. Thank you very much for being with us. Thank you, sir. Thank you, President, and the audience, sir. participant.
Sir, to sum up, I think today as everybody has told you that Mr. Abhishek has, presented in a very simplified manner a very complex issue, and we have been, to summarize some points have been put out that it is a voluntary participation first. Then he said privacy security is by design into it, and since it's a federated architecture, the data lies with the provider itself, and seamless portability is there, and that's how we create a longitudinal records. And then he also talked about the access and other issues. And the most important thing, the optimism in his talk was that he said when the critical mass is accepting, people will follow. I think that is the right approach to go ahead, rather than having a statutory framework being built up into it and leading to difficulties later on. And this health locker is a good concept. I think health locker is going to be actually, helping us to create permanent data records of the patients. With these words, I thank you, Mr. Abhishek Kumar, for a very elaborate presentation on behalf of all the HA members and our academic cell at HA. Thank you so much.
Thank you.
Thank you very much, sir. Thank you.